I'm going to talk about hemorrhagic shock and tourniquets. Andrew put a lot of pressure on me with keeping on time. I have a fair amount of information, and I live in a home with 3 young daughters, so I don't get a lot of time to talk at home. So when I have these opportunities, I like to milk it for everything that I can get out of it. So just want to kind of start out with our objectives, to identify the physiologic changes associated with the different classes of hemorrhagic shock. As we're going to go through, you can see that these physiological changes can be actually very, very subtle and even masked with people who are taking different types of medications. I had a gentleman the other day, motorcycle accident, bad open book pelvic fracture, blood pressure in the 70s, heart rate in the 60s. And he was 40 years old, but he already had a heart attack and he was on a beta blocker, so there was some subtle things that you had to pick up on. Learn the advantages and disadvantages of tourniquet use, and we're going to consider some items that you want to include when you're developing a protocol, and we'll talk about protocol development. So, background, hemorrhage is one of the leading causes of death among trauma patients. Peripheral vascular injuries are common on the battlefield, but also occur very frequently in the civilian setting. If not quickly controlled, peripheral vascular injuries can result in life-threatening sanguination. You can bleed to death very quickly, particularly from lower extremity injuries. So what happens to you when you bleed? Anyone? Nothing.
Always fluid.
Well, depends on how much blood you lose. Okay, so that's what we're going to talk about. So your normal adult blood volume is 5 liters. And to put that in another perspective, it's about a case of beer. Okay, so think about that amount of volume that a person has in their body. So what do we do to recognize who's in shock from bleeding, from hemorrhaging? We look at different things. We look at a person's mental status, are they altered, are they confused? We look at their pulse, are they tachycardic? Or is it heart rate? Are they tachycardic? Pulse? Do they have a bounding pulse? Do they have a thready pulse? Their blood pressure and their respiratory rate. So when we look at class 1 shock, that's bleeding of up to 750 milliliters of blood, or for our pediatric patients, 15% of your blood volume. That's kind of what it looks like, representation there. Put that in a different perspective, that's about 2 units of blood. The unit of packed RBCs is about 300, 325 milliliters of blood. And that doesn't account also for all the good stuff that's in there, like your clotting factors and your platelets. So that's kind of a different perspective on it. So what happens after you lose that much blood, 750 milliliters? It's almost a liter. Pretty much almost nothing. Your patients are still alert. Their pulse rates are normal, or their pulse pressures are normal. Their heart rate is normal or somewhat increased. If you're Lance Armstrong, your heart rate's in the 40s resting, maybe it goes up to the 60s, but you're still in that normal range. Your blood pressure is going to be normal, and your respiratory rate is going to be normal. Okay, so that's pretty subtle. Actually, it's a pretty significant amount of blood loss there. So then you move into class 2 shock, and so you cross that 750 milliliter boundary into the 1500 milliliters, and that's 15 to 30% of your blood volume there. So what happens there? That's when you start seeing some subtle changes. Your patient could be mildly anxious, a little bit confused, but still have a GCS of 15. Their pulse pressure could be slightly decreased, but that's kind of something that's subtle and you have to pick up on. Their heart rate could be a little bit elevated, but we often see trauma patients that heart rate's a little bit elevated, just from what's going on. Blood pressure is still normal, and respiratory rate's 20 to 30. So you can see that up to 1.5 liters of blood loss, the changes can be very subtle and then difficult to pick up on. So then we move into class 3 shock. That's some pretty serious bleeding. We have 1,500 to 2,000 milliliters, or 40% of our blood loss. And that's when you really start seeing the obvious signs of hemorrhagic shock. And by the time you get here, you're way behind. Okay, the patient's mortality is going way up. So their patients are anxious and confused. They're oftentimes you can't get them to lay down. They're trying to get up. Their pulse pressures are greatly decreased. You feel like a thready pulse. very, very tachycardic. It's not till here that you reliably see a decrease in your blood pressure. So, I mean, a patient's already lost about 1.5 liters of blood before they start dropping their blood pressure. So they're no longer able to compensate for the bleeding. And then they're also tachypneic. So it's not until we have this very large loss of blood volume that we have these very obvious, signs of hemorrhagic shock. So, this is something, you don't want to get here. You want to pick them up when they're in this area here. They're starting to get mildly anxious, when they're, the pulses are getting a little bit thready, and their heart rates are, starting to creep up. Because by the time they get up to here, the class 3, that's when they're decompensating, and that's when they're going to, so you're going to start having some big problems. So what about class 4 shock? This is when the patients are really in extremis. Greater than 250 milliliters and greater than 40% of their blood volume. So they're confused, they're lethargic, they can be difficult to arouse. Their pulse pressures are really decreased. You might have an absent, pedal pulse, you might have an absent radial pulse. Heart rate is very elevated. Your blood pressure is decreased and your respiratory rate is elevated. And these are important to recognize, all these classes, because I've, over the past year or so, had several patients that were in hemorrhagic shock, with various classes of hemorrhagic shock, and it just wasn't recognized, either both in the pre-hospital and in the in-hospital setting. So there's a trauma surgeon, David King. We'll talk about a little bit of his work with tourniquets later in the Boston Marathon. And he gave a lecture one time and said, "Don't be distracted by the obvious. We, as pre-hospital providers, you have a lot of data coming in. There's a lot of stuff going on. Yeah, a person might have an ankle that's twisted around 3 times, and that looks really gruesome. But the splenic injury that they're internally hemorrhaging from might be what's going to kill them, and you have to recognize that they're in shock." So, what do we do about hemorrhagic shock from the extremities? The Hartford Consensus was a national kind of committee that got together to discuss the implementation of bleeding control. And one of their statements they said was, "We are a nation of people who respond to others in need. It is no longer sufficient to see something, say something. Immediate responders should now see something, do something." So in the post-9/11, immediate post-9/11 period, I was living in the Northeast, up in New Jersey and Manhattan, and I remember seeing all these signs in the subways and in the area, see something, say something. So if you see something going on, you go and tell a police officer or some other official. But times have changed in the United States. Now there's too frequently there's active shooter events. There's terrorist events. Like the Boston Marathon. So we're in a position now where it's not, you're trying to prevent a terrorist attack, you're responding to something that's already happened. So this is what they kind of put together. And they're also the ones who are kind of proponents of the, it's called Beacon, or bleeding control program, where they want to develop kits and kind of include, personal protective equipment, a tourniquet, pressure dressings, and kind of put them out the same way we put out AEDs all over, areas like in the shopping malls, airports. So they have the same kind of availability. So if and when these events happen, there's the ability to control hemorrhage. So tourniquets for the control of bleeding in extremities. If you ever wanted to see what happens when a subway car runs over somebody's legs, that's it. But as you can see, is there a little pointer thing there? There's 2 tourniquets on both of their extremities, and these were applied to the patient, probably ultimately saved his life. So, a little background on tourniquets. It's not really new technology, but what we're doing with them is new. So they were first used in antiquity to control bleeding from extremities during amputations. You can see there's a nice little picture here of a guy kind of fully awake. He's got a nice little tourniquet there, and some other guy there with a nice saw whacking off his leg. So And from that, it evolved into a first aid maneuver to control bleeding and bleeding extremities. However, this technique for control of hemorrhage has been repeatedly debated and probably is still debated in the literature today. However, it's kind of the pendulum swinging towards the other direction, saying from no, don't ever use a tourniquet to yeah, in certain circumstances, tourniquets are very useful. So the kind of the moving away from using tourniquets was based on historic battlefield experiences that condemned the practice because of limb loss and complications due to tourniquets. And that was kind of in the the World War I, World War II, where tourniquets were applied and there were delays in transport. And yeah, you can't leave a tourniquet on indefinitely, because bad things are going to happen. Your limb needs blood flow. However, trauma care has matured, and recent data from the wars in Iraq and Afghanistan have caused a rethinking of the previous held beliefs that the use of tourniquets are bad in the pre-hospital setting. And we're going to talk about that. So, what are some of the advantages of a tourniquet? Stops hemorrhage, yeah, okay, good. So does holding pressure. So what's good about a tourniquet over just putting your hand on it? Yeah, exactly. That's one of the big benefits is, you have, it's just you taking care of a patient, or you and your partner taking care of a patient. There's multiple issues going on. They could have bleeding from their upper extremity, bleeding from their lower extremity, having an active airway going on. You just don't have enough hands. You also could have multiple patients that are bleeding. We're going to talk about the Boston Marathon bombing. There were almost 30 patients that were identified as having life-threatening bleeding that were cared for. So it exceeds your resources. So what we have here is they're pretty fast to put on. The new commercially available tourniquets. There was a visiting professor who came and talked to us last month, Brian Cotton from Houston. We'll look at one of the papers he published too. He had his 8-year-old son putting on tourniquets, to prove how easy they are. So they're big things. You give your providers, hands-free. It gives their hands-free to allow them to perform other tasks, and it also provides more reliable pressure over time. Kind of holding your hand on one area, you kind of get tired. You can move. So it's in place and it's reliable, it stays there. But with everything, there's disadvantages. So what are some of the disadvantages you guys think that you have with the tourniquet? What's that?
Lack of blood flow to the lungs.
Yeah, well, that's the big thing, is interference with both arterial and blood flow, or arterial and venous circulation, which can lead to ischemia. Okay? Risk of nerve injuries and skin necrosis. So having continuous pressure on the arm, you cut off the flow to the skin, you cut off the blood flow to the nerves, and you can actually have an extremity that is non-functional because of the tourniquet. You get limb ischemia and possible reperfusion injury leading to compartment syndrome. So what that means is that when the arm or extremity is not getting blood flow, it starts to build up toxins and cells start to die. As the limb or extremity gets reperfused, those cells that are dying expand, and the pressure in the arm actually, or leg can build up, and you get a condition called compartment syndrome, and that's actually can be life-threatening and can threaten the limb if that pressure gets too high. Tourniquets are also pretty painful. Did you ever wake up and you're sleeping on your arm or something, and that pins and needles kind of tingling sensation? Yeah, and as it wakes up, it gets pretty painful. So now you have a patient who is hypotensive from bleeding. You put a tourniquet on them. Now they're complaining about pain. Now you got to give them a hypotensive patient pain medication. So that's something you got to consider also. And then limited utility in treating hemorrhage from a junctional injury. So what's a junctional injury? Does somebody know what that is? Yeah, your shoulder or your groin. So you can't get a tourniquet up all the way onto your shoulder or all the way up into your groin. They are developing what they call junctional tourniquets, which are more kind of direct pressure devices, but they're a little bit more complicated to use, and I don't think the data is complete on how good they are. So, from the Hartford Consensus, we have recommendations for doing something. What's the something to do? Both ATLS, Advanced Trauma Life Support, and Pre-Hospital Trauma Life Support, both recommend direct pressure as the first line of treatment for bleeding extremity. And as we're going to see, I'm going to talk briefly about the Boston Marathon bombings. That's not exactly what happened in the bleeding patients there. So what's wrong with that? It's time consuming. You have one person dedicated to that patient. You can't necessarily dedicate that amount of resources just to one person. It can be technically challenging. You could have a large soft tissue injury. Trying to hold pressure over that whole injury might not work. May not completely control arterial blood flow, and multiple sites of hemorrhage for multiple patients, a mass casualty, or a patient could be entrapped in a vehicle or in a building, and you actually, if they're pinned at you have a dashboard, pins them at the mid thigh, and it rolls down, and then you have bleeding distal, from the extremity, you can actually get a tourniquet in that's exposed and control the bleeding that way. And it also has been suggested that greater than 50% of deaths after a penetrating extremity injury could have been prevented with early application of the tourniquet. So even though this is kind of recommended, it might not be the most practical thing. And then the American College of Surgeons Committee on Trauma, that's a pretty big organization. They came up with their evidence-based pre-hospital guidance for external hemorrhage control. And again, they say apply direct pressure. If direct pressure doesn't work, go to a wound tourniquet. And if it's on an extremity, if it's a junctional injury or not amenable to a tourniquet, then you can use a hemostatic topical agent and more direct pressure. So what are they basing this on? So what they did was they looked at 16 publications that investigated pre-hospital trauma for extremity hemorrhage. So out of those 16 publications, only one of those were conducted in the civilian setting. And we'll look at that study in a little bit. The rest of those, the other 15, were actually military applications of tourniquets. And we'll kind of look at the differences a little bit between the military setting. Do we have anybody who's in the military? Okay. Are you guys issued tourniquets, with your kit?
Yes, I think
so. Okay. So, the military has a great experience, and we'll look at that, compared to the civilian experience. They have, a lot more experience with it than I think currently than the civilian community. So the first recommendation was the use of tourniquets in the pre-hospital setting to control hemorrhage should be used if direct pressure is insufficient or impractical. So then they said, the panel looked at everything as a group of, senior people. They said that they believe that tourniquets used to treat extremity hemorrhage, it had a clear survival benefit demonstrated by large and consistent sizes in several studies. So, but that's all military studies. So there are a lot of studies from the military that shows that tourniquets work and that they save lives. But as we're going to look, that might not necessarily be the same case with the civilians, but we're looking at it. The panel discussed that direct pressure may be ineffective in the setting of major arterial injury or impractical due to circumstances due to limited manpower, unsecure scene, or complex extrication when a complex extrication is required. So direct pressure, but when not practically used tourniquets. So this is important. Using a commercially designed tourniquet, which has a windlass, pneumatic device, or ratcheting device, has been demonstrated to include arterial flow. And we'll look at the shortcomings of using non-commercially designed tourniquets that's actually came to light during the Boston Marathon bombings. So again, they discussed the military experience here with the varying types of tourniquets. They felt that those had proven effectiveness for including the arterial flow. And that's really the important part, is getting that arterial flow included. So what happens when we don't include arterial flow? We have, when we just include the venous flow. So what do veins do, kind of in general? Right, they bring blood back to the heart. So if you put a tourniquet on a patient that just includes the veins, all that blood, and doesn't include the arteries, all that blood that's would normally be going back to the heart is now coming out through your wound, and the wound is still getting supplied by the arterial flow. So while the intentions might be good to put a makeshift kind of improvised tourniquet on somebody, you could actually result in more hemorrhaging and actually do harm to the patient. So that's where this came from, that you need a commercially designed device, and those commercially designed devices apply a mechanical advantage, which is required to cause arterial obstruction. If you don't have a commercially available device and you use an improvised one, you still have to use some kind of mechanical advantage. Usually it's a windlass where you put like either a stick, or I believe the military even used to say use the barrel off of one of the weapons, M4s or something like that. So they recommend against the use of narrow elastic devices. Everything, what we have available to start IVs, that tourniquet that we use to start IVs, don't use those. Again, in the military experience, it is shown that those types of tourniquets aren't sufficient, and that when they impede the venous flow alone, it's inadequate and actually worsens the hemorrhage in these patients. So then number 5 is they suggest that improvised tourniquets be used only when no commercial tourniquets are available. And again, that's from the military experience. And again, we talk about if only venous flow is obstructed, then you're going to actually have worsening hemorrhage and increased complications. In 5, this is the last one, they suggested against releasing the tourniquets unless they've been against releasing a tourniquet that has been properly applied in the pre-hospital setting. It should only be released when a patient reaches definitive care. And we'll talk a little bit about that when we get to protocols. And they also suggest that when you have a prolonged transport time, that you should, and you need to release this pressure. Usually we're talking about over 2 hours before you reach your definitive care. The pre-hospital provider should be in direct consult with the medical advisor. So now let's look at the military versus civilian experience, because all these recommendations were based on mostly military experience. So can we apply our military experience to the civilian sector? Maybe yes, maybe no, but there's some significant differences. In the civilian sector, the use is far less uniform, and we're going to look at that when we kind of get to the protocol section. So in the military, there's one set of guidelines, and that goes out through all of the military. So everybody's kind of using the same protocols. In the civilian sector, every single EMS agency has a different protocol for the most part. Civilian patients have more consistent and more rapid access to pre-hospital providers. And that's, for the most part, especially in urban centers, pretty true. You call 911 and one of you, ladies or gentlemen kind of show up and take care of the patient. Lot shorter transport times. The Boston EMS published their experience with tourniquet use, and the average transport time was 14 minutes. So that's pretty quick. From the time they got there to the scene to the time they got the patient to the hospital, 14 minutes. So that's an average time. So that's pretty quick. So civilian pre-hospital care providers are not routinely under fire. Okay, I say routinely because unfortunately, occasionally, EMS providers are targeted. But in the military, healthcare providers, you're in a combat zone. There's people shooting at you. You don't have time to sit there and hold direct pressure while somebody's shooting at you. You have to control the bleeding, move the patient out of harm's way, and move on. And I know, I used to work EMS, and there was, if this scene wasn't safe, we didn't even approach it. It didn't matter. Until we were cleared, if it was an active scene, until it was cleared by the police, we didn't go in there. So that's a big difference. So in the civilian population, there's also a relative lack of high energy penetrating injuries and explosions in explosions. So what's a high energy injury? Is a
gun.
What's that?
Gun.
Is any gunshot a high energy? No. So you're talking about shotguns, AK-47s, AR-15s. You're in hunting rifle type rounds, like you're like a 308 type round. Those are actually high energy, and they're a lot more destructive than your typical handgun rounds, your 9mm, your 45, even your 357 or 44 Magnum. When somebody rolls into a trauma center with a gunshot wound, I can definitely see from the pattern of injury whether it was a high energy AK-47, AR-15 type wound versus a handgun. And there's not a lot of explosions in the civilian setting either, thankfully. I've only had a small handful of patients that were victims of explosions. Overall, the burden of injury is less in the civilians. So, you might have a patient who's shot once in the thigh in the civilian sector, where in the military you have patients who were victims of an improvised explosive device, and now they have injuries all over their body and multiple injuries to their lower extremities and upper extremities. So, the burden is a lot higher. So, and also we're looking at the upper extremity versus lower extremity. There's more upper extremity injuries in the civilian community than in the military community. Why do you think there's more? I kind of had to think about that. Like, why are civilians have more upper extremity injuries?
Close range.
Because your headsets are IED, like landmines.
So that's a big thing. IEDs, they're at ground level. They come down and they can take you out from that regard. In civilians, most of the upper extremity injuries, vascular injuries I've seen, are self-inflicted. People, cutting themselves, and we have a very high population of young individuals who like to get drunk and punch windows. I don't know what that's about, but I've seen quite a few of those. They can, you're intoxicated, your blood's thin, you've punched a window, you have a longitudinal incision on your arm that cuts the artery, you can bleed a lot from those, and you actually die from it. And there's a relative lack of data, from the civilian use of tourniquets. Well, let's kind of look at what we have available. So this is the one paper that they were talking about when it came to the tourniquet use in the civilian community. And this is the return of tourniquets. Original research evaluates the effectiveness of pre-hospital tourniquets for civilian penetrating extremity injuries. And this was from 2008 in JaxEMS. So they hypothesized that the pre-hospital tourniquets could safely and effectively control life-threatening extremity vascular injuries, and highly trained pre-hospital providers could apply tourniquets following guidelines. The study emphasized that these guidelines and the outcome of the patients who had the pre-hospital tourniquets should be applied in the field, and they described the patients who had the pre-hospital tourniquets, and they examined the appropriateness of the tourniquets and reported the effectiveness of the pre-hospital tourniquets on multiple aspects of patient outcome. So it's a relatively small study. When you're looking at the military experience, you're looking at thousands of patients, that they've put tourniquets on, and this is in multiple countries, not just the United States. Here, 11. So it's not a lot of patients. What was their protocol that they had in place? They had to have an extremity wound. They had to have a blood pressure less than 80 and severe loss of blood. They estimated the scene. And out of all these patients, all of them were taken to the operating room for surgical exploration. And the results were actually pretty impressive. When I looked at this, even though it was 11 patients, there was actually very good judgment applied. So there were 6 out of those 11 patients, 6 of them had gunshot wounds, and all 6 of the patients with gunshot wounds had a major arterial injury. So they were pretty good, that protocol worked at picking up the patients that needed. So one of the 3 stab wound patients had a major arterial injury. The other 2 had, muscular bleeding, and one had a blood pressure greater than 80, so it was kind of a protocol deviation there. And 2 of the patients with lacerations, those people who like to punch windows type people, they had major arterial injuries. So as you can see, most of these patients that tourniquets were applied to actually had a major arterial injury. So what they concluded from this was that pre-hospital tourniquets can be appropriately applied to control life-threatening hemorrhage and extremity injuries. So, and there wasn't any associated neurovascular complications. So that's a pretty good starting point. And then moving forward, this is, I think, from 2015 from the Journal of Acute Care Surgery. There was a retrospective review of 87 patients. Now we have more patients. And when they looked at those, when we used those, only one case out of the 87, they determined that the tourniquet contributed to a loss of a limb. But when they went back and looked at that one patient, the tourniquet probably saved the life anyway. So, life versus limb, you got to make a decision sometimes. So when you looked at major vascular injury as a marker for appropriate use, 80% of the patients, so almost, a majority of these patients had at least one named vessel injured. So in the trauma community, bleeding from named vessels like radial artery, ulnar artery, brachial artery, femoral artery, if it has a name on it and you're bleeding from it, that's significant bleeding. That means that vessel is big enough to be recognized and get a name. If you're bleeding from that, there's a good chance you're going to not do well unless that hemorrhaging is controlled quickly. And of those 87, 70% of them were applied. So the majority of them were actually, the tourniquets were applied before the patient got to the hospital. And, of the 20%, those patients had extensive soft tissue injuries, which the muscles are very vascular and they can actually bleed extensively also. So they were deemed to be appropriate. So their conclusions was tourniquet use in the civilian sector is associated with a low rate of complications, and with low complications and a higher potential for benefit, aggressive use of this potential life-saving intervention is justified. Okay? So now we're making this transition from the military data to the civilian data. And this is the last study we're going to talk about for the translating the military data to the civilian data. This was done by Brian Cotton. He was here last month talking with us about this. And they just published this out of Houston, and they have a very aggressive program there. He was saying that all of your immediate responders, have tourniquets available to them. So the police have it, all the EMS have it. So there's a lot of people out there with tourniquets. So we went through this study, which is 11 patients in 2008. That was over a 7-year period. So in 7 years, this one hospital only got 11 patients. And then the study here, this was only a study that was a couple of years, like 2-3 years, maybe a little bit longer, but they had 105 patients. So, and this is actually, we published this last month. So you can see that in just an 8-year period, we've gone from just barely using tourniquets, in pre-hospital to, it being having a significant presence. So they said that out of the 105, when they reviewed the charts, it's kind of hard when you go back and look at the charts. 94 of them were appropriately used. They were having patients with arterial bleeding or major soft tissue bleeding, and those were appropriate, definite, easy to see, that there was an indication for it. The other 11, somebody may have put it on a little bit premature, but it was difficult. They said it was difficult to ascertain given the information that they had available to them. So 41 of those 70 patients, or 41 of the 94 patients that they had with the appropriate use had major vascular injuries. Okay, so about half of the patients had a major vascular injury that needed to be repaired, and the other patients probably had venous injuries or bleeding from large soft tissue injuries. However, there was a 0% complication rate due to the use of tourniquets. And that even included the 11 patients that somebody kind of put the tourniquet on a patient that may or may not have been indicated. So now we're getting a large accumulation of data saying that yes, we can use these tourniquets in the pre-hospital setting, and we could do it safely. So his conclusion was pre-hospital and in-hospital personnel are capable of applying tourniquets to the appropriate patient regardless of the patient's age or mechanism of injury, blunt versus penetrating. Okay, so now we're making that transition from the military data to the civilian data. So tourniquet protocols. We have a lot of JFRD here. Do you have a tourniquet protocol?
Yes.
We do now.
You do now. When did it get implemented? What's that?
It's been about 4 months.
About 4 months. Yeah, and it's the same thing with Trauma 1. When I took over Trauma 1 as the medical director, we were in the process of reviewing our protocols. And we'll talk about, David King. He looked at the Boston bombing and national protocol use for tourniquets. And we kind of fell in that middle scoring thing where it said we had, if you cannot control extremity bleeding with direct pressure, use a tourniquet. It doesn't say what kind of tourniquet, it doesn't say how to apply it, it doesn't say anything, it just says use a tourniquet. So do we need them? I would say yeah, and we'll talk about why. And if we do need them, what should we include? And I made a kind of a list of things of what to include. So Boston bombing, David King, he's a trauma surgeon, very nice guy. He actually ran the marathon, finished, the detonations happened, and then went to his hospital where he worked and started operating on victims. So, pretty impressive guy. And also very, very, very nice. He's the one who talks about don't be distracted by the obvious. That twisting leg might be pretty gross with the bone sticking out, but don't get distracted by that. Go for what's actually hurting or killing the patient. So after the Boston marathon bombing, you can see they had 29 patients with recognized bleeding from an extremity. And of those 29 patients, 27 of them got tourniquets. So go from that applied direct pressure, as first line to now tourniquets that were used as the first line. And there was a lot of people who kind of referenced that, saying, tourniquets, save lives. And I think of those 27 people, or actually all the patients, all the 29 patients who had recognized bleeding, who made it through the hospital, nobody died. So they're saying, well, we had 29 patients, 27 got tourniquets, and nobody died. So this is great. Tourniquets save lives. And David King said, whoa, wait a second here. Let's look at that. Association doesn't mean cause. Just because somebody came to a hospital with something wrapped around their extremity doesn't mean that it worked. Let's look at this a little bit more in depth. So there's actually a database. They kind of all the patients who got injured at Boston Marathon, he went into that database and looked at it, and he found in that database all of the tourniquets that were applied were improvised. Not, he could not find documentation of one patient that had a commercial tourniquet applied. And those are including the ones that were applied by EMS, the first responders, the paramedics and EMTs. He did say that he did find one picture or a video of somebody with a commercially applied tourniquet, in the field, but he couldn't find what ultimately happened to that patient, so he couldn't really comment on it. So of those 27 patients, he found documentation at the hospital on 8 of those patients saying that ongoing bleeding was occurring when they reached the hospital. Okay, so that's a pretty high percentage, of patients who are still bleeding. One hospital actually had very, very good records, with pictures and everything, and he said that that hospital received 6 of those 8 patients with improvised tourniquets, and they had ongoing bleeding because the tourniquets were only venous tourniquets, and they required the commercial CAT tourniquet to prevent ongoing bleeding. And the most common tourniquet that was used was the EMS, tourniquet was a rubber tubing with a Kelly clamp. That was their improvised tourniquet. So he's like, well, wait a second. Yeah, all these people came in with tourniquets, but they might not have been doing the job, that we hoped they were doing. Then he took it a step further. He looked at a 42 state review, and they looked at who's using tourniquets, and they found that there's really no standardized approach to it. Most places, including Trauma One until recently, and it sounds like JFRD until recently, kind of fell in this kind of category where it says tourniquet mentioned without specific guidance. Like, yeah, use a tourniquet, but that's when you run into situations like this. Well, I was told to use a tourniquet. I'm just going to put a piece of rubber tubing around and call it a day. So he went throughout the United States. He found considerable variability. The nationwide, most states didn't have a uniform, detailed, aggressive pre-hospital protocol for control of exsanguination, and he thought it would be beneficial to have these kind of standardized protocols. So what should we include? And what's the purpose? The purpose is to get everybody on the same page, minimize blood loss and the morbidity and mortality associated with bleeding from an extremity. So considerations, these are what I went through looking at everything. This is what I considered when we were developing our protocol. Design. It should be a commercially available tourniquet specifically designed for that purpose. You want to minimize the risk of tourniquet-related complications. Blood pressure cuffs. Who has ever seen somebody with a blood pressure cuff on? Yeah, they can work, but they're not designed to hold pressure consistently over arterial pressure for extended periods of time. They gradually lose pressure, and you can have recurrence of bleeding. And the wide girth of them, they're pretty wide, might not be sufficient when you have a short stump. If you have a very high amputation either on the leg or on the thigh, so you might not be able to get that on. So don't rely on the blood pressure cuff as your tourniquet. Get one of the commercially available ones. That's what they're designed for. That's what they're very good for. So, initial assessment and determination of need. So you want to make sure the patient actually needs it. So severe bleeding, not controlled by direct pressure, severe bleeding and other associated injuries, unstable airway, an open chest wound, and the number of patients. This might be a patient that you can control with direct bleeding, but you have 4 other patients that need your help. Tightening, like how the tightness depends on how severe or profuse the bleeding is. You want to know whether you're controlling arterial or venous flow. And simply stated, the tourniquet should be gradually tightened until the hemorrhage stops. And you should also reevaluate the patient. Because as the patient gets resuscitated, their blood pressure goes up, and while you had it tightened enough to stop the bleeding initially, now they're bleeding again, and you might have to retighten it. So never obscure the tourniquet. It should be in the protocol. Don't cover it with clothing. You should clear the clothing away. Don't ever put a dressing above it. Mark it with the time and a date, and secure the tape to the tourniquet. You ever try to put tape on a sweaty, bloody person? It doesn't work. The tourniquets are usually dry, and you can get it on there. Some tourniquets even have an area you can write on it, or on the skin next to the tourniquet of the forehead. This is, I want in a 24-hour clock format and a date. This is important. I had a patient who was in the Caribbean on a golf cart, got hit by a truck, and had a tourniquet applied to his upper extremity. he didn't get to me for over 12 hours. So he had a tourniquet in place for over 12 hours. So if they would have written on the tourniquet, 9 o'clock, so when I got him at 10 o'clock or 11 o'clock, I'd be like, oh, the tourniquet's only been on for 2 hours, when it's really, it's 9 a.m. and now it's, 2100 and it's been on for over 12 hours. So that's important. And also the date, because you just don't ever know what's going to happen. As I said, this person was sitting in the Caribbean for a while before he got to Miami, and he could also, they could put it on 9 o'clock in the morning, and then, it's 10 o'clock the next day, and I can only think, oh, this has only been on for, an hour. So that's just avoids confusion. And then, reassessment we talked about, you want to frequently reassess it. And then lastly, removing the tourniquet. Do you need a protocol for removing the tourniquet? I would say in an urban center here, no, we don't. I think our transport times are under 2 hours. If you're in a rural setting like Alaska, or in the middle of Montana somewhere, and it's going to be several hours, that's something you have to sit down and talk about. I think in the military they might have a removal protocol. They can actually have it where you put it on, and then you can get your gear together, apply direct pressure, and slowly release it. I'm not in the military. I don't know exactly what their protocols show, but if you're going to be, you anticipate you're going to have large or long transport times, this is something you should probably consider while making your protocols. All right, so in conclusion, we have a vast amount of data showing the benefit of tourniquet use in the trauma combat setting, a limited amount of data in the civilian setting. However, this data is improving, and it's actually showing consistently that we can safely use tourniquets in the civilian setting. Standardized protocols may help show a benefit in outcomes, and additional research is needed. One thing that's missing from the civilian data that's actually they're working on now is that, say, we've already proven that, yeah, we can safely use it, but now we have to prove that it's going to improve outcomes and save lives. Thank you for your time, guys. Thank you.
As far as placement of the tourniquet, do you prefer it to be placed closest to the injury or further?
It should be as close to the injury as possible. That's not always practical. When we talk about in a trap, I said, person's pinned in a vehicle, pinned in a structure, bleeding distal, and you might only be able to get they might be bleeding down by their ankle, and you can only get a tourniquet up, just above the knee. You have to evaluate it. You have to, do light versus limb, and then, if after they're extricated, you can consider reapplying the tourniquet more or closer to the injury, and then releasing the more proximal.
And in the future, will there be a consideration for using quick clot?
We use there's the pads or the device or the hemostatic agent that you pour into the.
That's it.
We actually use them in the trauma center here. We have them available. We have the long ribbons. We have the large trauma pads and 4x4s. So we have them available here in the trauma center and in the trauma OR. So it actually is something that we do use. I think it's a good product. I think it has limited utility, but it's something, it's an adjunct to other stuff that's available. I think it's great. You can use it to hold direct pressure. I've seen it work well with intra-abdominally with liver injuries in patients who are kind of anticoagulated on your Coumadin, type medications where you hold pressure and it will aid with that.
Can you explain a little bit more about what that is?
So quick clot is a.
You said strips or bands and something.
Well, it's like a long kind of ribbon type dressing. So it's about 2 or 3 inches, or 3 or 4 inches wide, and it could be several yards long, and you can actually kind of wrap it around. Or it comes in your standard 4x4 type configuration. It comes in ABDs. It comes in what we call laparotomy pads, which are sponges we use in the OR, and it even comes down as like 2x2s. And it's commercially available. You can actually go on Amazon and buy it for your home first aid kit. It's actually pretty expensive. Small package is like $30 or something like that, but it's a pretty good product. And it has on it. It has a hemostatic agent, which helps the blood, helps you form clots.